This video shows the Maverick technique, a modification of previously described medial collateral ligament reconstruction techniques to restore valgus and anteromedial rotatory stability. The authors have no conflicts of interest. Patient is placed supine with a foot post and a lateral support. The knee is bent to 90 degrees, and after having identified osseous landmarks, an anteromedial longitudinal incision is made, extending from the medial epicondyle to approximately 6 centimeters distal to the joint line. The deep fascial layer is incised along the full length of the superficial medial collateral ligament and the pes anserinus exposed. The semitendinosus tendon is identified and harvested, preserving its tibial attachment. Since the semitendinosus insertion is more anterior than the distal superficial medial collateral ligament insertion, to redirect posteriorly the graft, a first anchor is placed about 6 centimeters distally from the joint line, at the midpoint of the antero-posterior distal footprint of the superficial medial collateral ligament. Subsequently, a second anchor is positioned along the course of the native superficial medial collateral ligament, about 20 millimeters distally from the joint line, at the same line of the previous anchor on the anterior-posterior plane. The graft is therefore passed under the remaining pes anserinus and fixed to the distal and successively to the proximal anchor. Next, the proximal insertion of the native medial collateral ligament at the medial epicondyle is exposed, and to determine the isometric point, a K-wire is placed on the medial epicondyle. One end of the graft is wrapped around the wire, while the knee is flexed around the full range of motion. In this case, the graft slackens in extension, so a more posterior K-wire is placed and the isometry tested again. If the chosen point is satisfactory, a breath pin is placed. The isometry is therefore checked again, going through a full range of motion while holding the graft wrapped around the wire. Once the isometry is confirmed, a bicortical tunnel is drilled using a 4.5 millimeter drill bit. Subsequently, a half tunnel is drilled to the same diameter as the graft, 6 millimeters in this case, to a depth of 25 millimeters. The graft is then passed through the loop of an adjustable button and shuttled into the femoral tunnel using the Beath pin, and thereafter fixed in suspension with the knee held at 30 degrees of flexion and slight varus. Finally, the distal footprint of the deep medial collateral ligament on the tibia is identified, aiming at a point placed anterodistally at a 25-degree angle from the previous bundle, approximately 10 millimeters distal to the joint line. The third anchor is then deployed, and the graft is fixed at the tibia in a neutral position with 30 degrees of flexion. The final construct is checked, and if some extra tension of the graft is needed, the adjustable loop of the button can be further pulled in full extension to prevent flexion contracture. The native superficial medial collateral ligament is sutured over the graft, and the deep fascial layer is accurately closed.